started. My name is Sulik, and I'm a PGY2 Geriatrics pharmacy resident here at the South Texas Veterans Healthcare System. And today I'm going to be presenting on inappropriate sexual behavior in dementia patients. I first want to start with a case. Mr. J.W., who's a 69-year-old male with dementia secondary to anoxic brain injury after a cardiac arrest. His past medical history includes hypertension, atrial fibrillation, depression, dementia, and CAD. His inappropriate sexual behavior includes groping women, usually female friends, in family, as well as exposing himself in public. His family has become very uncomfortable with him because of these behaviors, and it has affected their daily lives. He used to go to daycare, but he exposed himself to one of the bus drivers, and he can no longer attend that anymore. I want you to think about Mr. J.W. as we progress through the presentation, and I'll come back to him at the end. The objectives for today are to define inappropriate sexual behavior as well as the causes, to describe behavioral interventions available for treatment, as well as look at the evidence for pharmacologic treatment in inappropriate sexual behavior and what those risks are. We'll also look at ethical dilemmas to consider when initiating therapy. First, I'd like to briefly review some of the more common types of dementia, including Alzheimer's disease, dementia with Lewy bodies, and vascular dementia. As the cases I present, the patients will most likely have these types of dementias. So Alzheimer's disease has multiple hypothesized pathologies. One of the more common ones is neuritic plaques and neurofibrillary tangles that develop, lead to degeneration of neurons and synapses, and also destruction of cholinergic pathways. Some clinical characteristics of patients with Alzheimer's disease include impaired executive function, as well as behavioral disturbances, and they are unable to perform their activities of daily living. Dementia with Lewy bodies have the presence of Lewy bodies in specific areas of the brain. Some clinical characteristics for these patients are cognitive fluctuations, so they can have periods of clarity. They often have hallucinations and delusions. They can have Parkinsonism-like characteristics and are often very sensitive to neuroleptics or antipsychotics. And then finally, vascular dementia is associated with cerebral vascular disease. And these patients usually have a history of strokes. And common clinical characteristics include early and severe decline of executive function. They can have personality and mood changes, as well as urinary symptoms and gait disturbances. First, I'd like to define what inappropriate sexual behavior is, which I'll refer to as ISB. You may be wondering if that's actually been defined in the literature, and there's are actually a couple of definitions. The most common is persistent, uninhibited sexual behaviors directed at oneself or others. And these behaviors can cause distress, disturbance, or suffering for close relationships and caregivers. It is categorized into two different areas: an intimacy seeker or disinhibited. An intimacy seeker has behaviors like kissing and hugging, which are in the wrong social context. But disinhibited can have fondling, exhibitionism, and vulgarity, which are not appropriate in most social contexts. There's also different types of hypersexual behavior, including sex talk, implied sexual acts, and sexual acts. Sex talk includes foul language and is usually the most common. Implied sexual acts includes unnecessary genital care or publicly reading pornographic material. Sexual acts include touching, groping, grabbing, exposing, or masturbating in public. Now that we reviewed what ISB is, let's look and see how common is it and what's the prevalence. There was a retrospective review of 133 demented patients that were admitted to an inpatient unit. The reported prevalence was 15%. They also looked at what type of dementia these patients had, with the highest being vascular dementia and Alzheimer's disease. Another retrospective cross-sectional study looked at over 2,000 charts. The prevalence reported here was about 2%. So you can see there's a wide range reported in the literature of how prevalent ISB is. They looked at male to female ratio, and most of the patients were male. They also looked at what type of dementia, and again, vascular and Alzheimer's disease was the most commonly reported. And they looked at what types of behaviors, if it was physical or verbal, with most patients having both types of behaviors. The literature shows that ISB is associated with dementia, but what could possibly be the relationship, or what changes are occurring in dementia that may lead to these behaviors? Some changes may be seen in the CNS, in specific areas of the brain, such as the frontal cortex, which can lead to disinhibition. The temporal limbic system can impair emotional and intellectual understanding of sexual arousal. Changes in the striatum can cause obsessive compulsive sexual behaviors, as well as changes with the hypothalamus can increase sexual drive. Besides changes in the CNS, there may be different endocrine factors that affect ISB, including testosterone, which influences sexual desire in both males and females. And it's been shown that rapid withdrawal of testosterone can lead to a decrease in sexual interest of males. Estrogen plays a smaller role in sexual behavior, but high levels do inhibit sexual desire in males. Progesterone has not been shown to substantially affect sexual behavior. Neurotransmitters also play a role in causing ISB. Two that I'm going to focus on are serotonin and dopamine. Serotonin is not only located in the CNS, but also in the periphery, and may affect smooth muscle vasodilation and vasoconstriction of sexual organs. Dopamine increases actually increase sexual desire in males, or has been shown in males, but there's not much data in females. There's a relation between the two, so if there's a low CNS serotonin level and a high dopamine level, that can increase sexual desire. The opposite is also true, so a high serotonin and a low dopamine level can decrease sexual desire. Medications are also important to review, such as dopamine agonists, which increase dopamine, which are just stated that increased dopamine levels can lead to increased sexual behaviors. Direct dopamine agonists, such as bromocriptine or pramipixole, are more likely medications that can cause these behaviors. There were 2 reviews of patients on dopamine agonists, 15 patients in each of the reviews, and in one, 14 of the 15 patients developed hypersexuality within 8 months of starting dopamine agonists. And 7 of the 15 patients with these behaviors were also on the other review on dopamine agonists. In both of the series, symptoms are resolved when the dopamine agonists were discontinued, but there may also be a dose-dependent relationship, so lowering the dose may also cause the behaviors to cease as well. Additional medications include alcohol and benzodiazepines, which can cause disinhibition, as well as stimulants that can lead to increased libido. I have discussed possible causes of ISB, and what is there that we can implement to help treat these behaviors? There's 2 categories: behavioral interventions and pharmacologic interventions. For the pharmacologic interventions, I'm going to focus on antidepressants, hormonal agents, antipsychotics, and anticonvulsants. There have been other drug classes studied, but these have the most data available in the literature. What I'll be presenting are case reports, as that's the level of evidence that's available for looking at efficacy in treating ISB. It's not an all-inclusive list of the case reports. I'm going to be focused on the case reports that report the most information. So first, with behavioral interventions, it's important to think about the patient, but as well the family and the caregivers. So if you think back to Mr. J.W., his behaviors were causing a lot of problems within his family. So supportive psychotherapy for family and caregivers is important for the caregivers to know that how those behaviors are not a reflection of their relationship with their loved one. For patients, there's a variety of behavioral interventions that can be tried, including redirection and distraction. Also, sensory stimulation, especially patients that expose themselves publicly or masturbate in public to keep them busy, if that's arts and crafts or folding towels. You want to separate them from social situations that exacerbate these behaviors, such as in a nursing home, give them the same-sex nurse, or if it's time to eat in the dining area, sit them away from another resident that may exacerbate those behaviors. You also want to set aside privacy arrangements for the individual and if they have a partner. And then one of the neat interventions, I think, is the clothing, especially for patients that expose themselves or masturbate in public, is what they call clothing that has a back flap. So the cartoon kind of depicts this, but it would be in the other direction so that they can't do that. There's not a lot of evidence in the literature that shows how effective these behavioral interventions are, but there was a case report as well as a case-controlled study. There was a case report of a 68-year-old male with Alzheimer's disease who had been inappropriately touching staff and female residents. He was started on antipsychotics, but it only slowed him down. He was provided a stuffed toy, which was a pink panther, and he became less intrusive towards staff and residents as he directed his behaviors towards the stuffed toy. The case-controlled study looked at what type of interventions are being used when they changed the type of care provided. So in the control group, residents received regular care, but in the intervention group, it included a nurse and clinical psychologist, which the residents received individualized plans and extensive assessments, and their behaviors were analyzed in detail and a risk assessment was completed. Now, looking at the intervention group, psychosocial interventions were used much more than pharmacologic interventions. But in the control group, psychosocial interventions was only 9% compared to the intervention group, which was 77%. It was reported that the intervention group did have a 44% reduction in difficult behaviors. The statistical significance of this was not reported, but it seemed like that would be clinically significant. There are limitations to behavioral interventions. There's a reduced ability of the patients to learn and remember because of their dementia. Also, there may be poor education of training and staff, training the staff and the caregivers. The strengths to using behavioral interventions is that there's no adverse effects and it's non-invasive. The first drug class I want to talk about are antidepressants, specifically selective serotonin reuptake inhibitors, or SSRIs. The proposed mechanism behind these medications is that they increase the serotonin, leading to anti-libido and anti-obsessional effects. They're usually well tolerated, but they can cause gastrointestinal effects, and some of them have a high risk of QTc prolongation. The majority of the case reports are with citalopram 20 milligrams daily. I'm just going to highlight two case reports. One was in a 55-year-old male with Alzheimer's disease, where his wife reported he was irritable and having hypersexuality with greater than 20 sexual outlets per week. He was on donepezil 10 milligrams daily, which had no effect on his ISB, and he was started on citalopram and titrated up to 40 milligrams daily. And on that dose, his sexual outlets decreased to less than 2 per week after 2 months. Another case report was in an 85-year-old male with mixed Alzheimer's disease and vascular dementia. He had interest in adult pornography, which his family found and hid from him, and he would get very obsessed with trying to find those items again. And he decreased his normal hobbies that he used to do. He was started on citalopram and titrated up to 20 milligrams daily. And at the 7th-month follow-up, the family reported reduced ISB, as well as he was no longer interested in finding the pornography. Another drug class are antipsychotics. The main mechanism behind these for treating ISB is their dopamine blocking effects. So decreasing the dopamine can decrease the sexual desire. It's important to remember with these medications the side effects, because there are a lot and many of them can be severe, including the ones I have highlighted in yellow: extrapyramidal symptoms, QTc prolongation, and metabolic changes. There's also a black box warning of increased mortality in elderly patients with dementia-related psychosis. So it's best to weigh the risk versus benefit when initiating these medications. One case report was with quetiapine in an 85-year-old male with dementia. He attempted to have sexual relations with his wife and would masturbate for several hours if she verbally refused. He was started on CPA, or cetirizine acetate, which I will go into detail in later slides, and paroxetine, which did not decrease his ISB. He was then started on quetiapine, 25 milligrams at bedtime. It was reported that his ISB stopped after 2 days, and there was no recurrence at 2 months. Another case report with quetiapine was in a 61-year-old female with dementia Lewy bodies. She had expressed sexual wishes towards family and friends, including touching. She was currently receiving levodopa, carbidopa, olanzapine, and memantine. She was started on quetiapine, 75 milligrams daily, and it was reported that her ISB was reduced after 7 days. And marked improvement was shown in her ISB and maintained at 1 month. For the majority of the case reports with antipsychotics, the duration of effect is limited to a couple of months, or that's what's been reported in the literature. Hormonal agents are also used for ISB, including anti-androgens and estrogens. Anti-androgens include medroxyprogesterone acetate, or NPA, and cetirizine acetate, CPA. Different derivatives of estrogens, such as ethinyl estradiol, conjugated estrogens, and diethylstilbestrol, have been used for ISB as well. With these medications, they both decrease testosterone levels, which by some are considered chemical castration, which I'll go into detail later in the presentation, but I want you to keep that in mind as I go through the cases. So hormonal agents reduce testosterone. NPA and CPA are very similar in how they work. NPA's effects are usually seen within 1 or 2 weeks, and CPA takes a little bit longer. So since they lower the testosterone levels, it's been proposed that maybe measuring the testosterone levels can help you determine what dose to use of these agents. There's no set guideline of what level of testosterone to target. There's been proposed decreasing the testosterone levels from baseline by 90%, decreasing the testosterone levels to what a female patient testosterone levels are, but none of these have been explicitly defined. These agents do have a lot of side effects. The ones highlighted in yellow are more common or more severe, especially thromboembolism, decreased bone mineral density, and cardiovascular disorders. It is contraindicated to use these agents in patients that have thromboembolic disorders. CPA is not available in the US, so I'm not going to be discussing case reports with that agent, but there are those available that have shown efficacy. I do want to highlight a case series done with NPA. There was an 81-year-old male with Alzheimer's disease that had ISB, including touching female family, staff, and residents. He was on sertraline and quetiapine, which did not decrease his ISB. He was then started on NPA, 100 milligrams IM every 2 weeks, which was increased to 500 milligrams IM weekly. It reported that his ISB was completely stopped, and that was maintained for over a year. Another patient, a 68-year-old male with vascular dementia, had public masturbation and also ISP touching females, who trialed on a variety of medications, including quetiapine, trazodone, valproic acid, and risperidone, which did not decrease his behaviors. He was then started on MPA 300 milligrams IM weekly, and again it was reported that his behavior ceased almost immediately. And finally, an 81-year-old male with dementia had behaviors of touching females, residents and staffs, and also reported to have sexual relations with another resident at the facility. He was on donepezil and quetiapine that did not affect his behaviors, so he was started on MPA and increased up to 500 milligrams IM weekly. Again, it was reported that his behavior stopped and that was continued for at least a year. There was recently a case series of 10 patients, all males, with the average age of 80 years, that were admitted to an inpatient psychiatric unit for inappropriate sexual behavior. Of those patients, 40% had been first treated with SSRIs, then atypical antipsychotics, and then oral NPA as third-line therapy. Which is interesting with this case series that they used oral therapy. NPA does not come in doses as high as what's used. They use a range of 100 to 400 milligrams daily, but they had it specially compounded. The primary outcome was if the residents or the patients went back to their prior living arrangements since they had been admitted for these behaviors. And 70% of the patients did return to their prior living arrangements. Estrogen also causes testosterone to decrease, so the mechanism is very similar. Again, there's side effects to consider. They're similar to the anti-androgen side effects. To keep in mind the cardiovascular side effects as well as thromboembolism, and it is contraindicated to use them in patients that have thromboembolic disease. One case report with estrogen therapy was in a 78-year-old male with vascular dementia. He had inappropriate sexual behavior towards female staff. He was trialed on a variety of medications using risperidone, lorazepam, and haloperidol as needed. They wanted to start conjugated estrogen, 0.65 milligrams daily, and they did get consent from the guardian to initiate this therapy. After about a month and a half, the behaviors reduced, and at 5 months, it was reported that there was 80% improvement in sexual aggression and 55% decrease in sexual talk. Anticonvulsants is another class of medications that have been used in treating ISP. Mainly I'm going to focus on gabapentin. The mechanism behind gabapentin for this indication is not clear. There's been some proposed mechanisms, one being that increase in GABA synthesis can lead to different changes in monoamine transmitters. Usually gabapentin is well tolerated by patients, but it can cause drowsiness as well as gastrointestinal effects. It does require a dose adjustment for renal impairment. In one case report with gabapentin, there was a 76-year-old male with Alzheimer's disease who had behaviors including exposing himself in public, touching female family, and masturbating in public. He was trialed on quetiapine, which did not decrease his ISB. He was also trialed on firm behavioral and nursing interventions, which did not have any effect on his ISB. He was then started on gabapentin and titrated up to 300 milligrams 3 times a day. And it was reported that his ISB resolved and that was maintained at 6 months. There was a small case series of 3 patients, 1 with vascular dementia and 2 with Alzheimer's disease. These patients had no effects seen after using behavioral interventions, so they were started on gabapentin and titrated up to doses ranging from 1,800 to 2,700 milligrams per day. 2 of the patients had marked improvement, with 1 patient showing complete resolution. And these improvements were maintained at 6 months. So I talked a lot about a variety of medications that have been used to treat ISB. I just wanted to review them briefly. So we talked about SSRIs that will affect serotonin and increase serotonin to possibly decrease sexual behaviors. Also, atypical antipsychotics, which have dopamine blockade effects, could decrease ISB behaviors. With anticonvulsants, the mechanism isn't really clear of which area they're acting upon. And then with the hormonal agents, they don't act in the CNS, but they do decrease the testosterone levels. In addition to case reports, there's been one retrospective chart review with a purpose to identify potential contributing factors, as well as to review the efficacy of different interventions. Patients were enrolled or included in this chart review if they had been admitted to an inpatient unit specifically for ISB. In the study group, there was only 10 patients that were found after reviewing 3 years worth of data, and they then developed a matched group based on gender, age, and marital status. This table shows some patient characteristics. The average age was 76 years old. The majority of the patients were males, 9-to-1 to females. When looking at the diagnosis of dementia, all the patients in the study group had dementia compared to half in the matched group. And if you look at the type of dementia, the majority of them had vascular dementia. 8 of the 10 patients in the study group had a prior stroke. And of those patients that had a stroke, 6 out of 8 had a right frontal stroke in the study group, which was statistically significant. Their MMSE score also was statistically significant with the lowest score in the study group. A variety of different interventions had been used in these patients, including antidepressants, antipsychotics, and hormonal agents. What's important to note is that these treatments could be used concurrently, so they were on multiple therapies. And the duration was a wide range from a couple of days to over 11 weeks. The efficacy was reported as no reduction in ISB, some reduction in ISB, or complete reduction in ISB. And when looking at these patients, none of the patients had complete reduction of ISB, but most of them having some reduction. They also looked at any adverse events, and there were 5 patients that discontinued therapy due to adverse events. The authors concluded from this review that there is a higher association of ISB with the diagnosis of vascular dementia, and if they had a right frontal lobe stroke and with more severe dementia. They concluded based on the interventions that citalopram was safe, but not as well and not as effective. Atypical antipsychotics seemed helpful, but they did have a lot of adverse effects. And then hormonal agents were well tolerated and effective. They did note that ISB seems to be underreported in the medical chart, as over looking in the past 10 years, the past 3 years, only 10 patients had that reported. The strength of this review is that it just adds to the limited data that there is, because everything else I presented was case report. There are a lot of limitations to this review. There's a small sample size of only 10 patients. It's retrospective study design. They didn't correct statistically for multiple comparisons, and it's also difficult to differentiate between the therapies as they could be on multiple combinations. After reviewing the evidence, the behavioral interventions are often not well described in detail, and there's not a lot of evidence in the literature showing how effective they are. There was one case report and one small controlled trial. The majority of the evidence is case reports, and usually only positive case reports are noted in the literature. And most of the residents in these case reports were on multiple therapies. There's no randomized controlled trial to demonstrate efficacy, safety, or dosing, and there's no trials comparing different agents. We discussed many different treatment options, but before even initiating therapy, there's a couple of ethical dilemmas to consider. I'm going to pose a couple of questions to think about as we progress through the slides. So first, should a resident be allowed to have a sexual relationship? And many of these questions apply to a nursing home facility. You may be thinking that's an odd question, but it's been estimated that 80% of 50 to 9-year-olds are actually sexually active. And recently, in the past couple of years, the rate of STDs in this age group has increased. And I don't know if you watched Parks and Recreation, but they had an episode recently of wanting to implement sex education in nursing homes. Should 2 demented persons, or 1 demented and 1 non-demented person, be allowed to participate in a sexual relationship? To really answer this question, it's important to think about capacity to consent. And capacity consent usually includes voluntary participation, mental competence, and awareness of risks and benefits. There has been some literature looking at capacity to consent to a sexual relationship, including, are they aware of their relationship? Do they know, especially in dementia patients, who the other person is? Do they have the ability to avoid exploitation? Do they know what they're comfortable with? And are they aware of the potential risk if their partner leaves? Do they know what would happen? Does restricting a resident's sexual expression follow federal regulations which mandate as least restrictive as possible institutional care? This question is difficult to consider as you have to weigh the resident's autonomy and right to sexual expression versus potential risks to themselves, to staff, and to other residents. Does chemical castration with hormonal agents violate the human rights of the patient? I briefly touched upon chemical castration, and there were some case reports that hormonal agents were stopped due to it being considered chemical castration. And there are different regulations in different states, but it's not always clearly defined. It's important if initiating any of these therapies to obtain consent if the patient is able to, if not from the caregiver or guardian to initiate these therapies. And again, you have to balance the rights of all the parties. In summary, there are multiple causes of ISB. Behavioral interventions seem effective but require time and training. There are multiple pharmacologic agents that have been evaluated, but there's little evidence. The elderly population is also at risk when using these therapies due to side effects. And before considering starting therapy, you have to consider the different ethical dilemmas. So when looking at initiating therapy, it's important to weigh the risk versus benefit, as no drug class has more significant evidence versus another. Safety should be a prominent factor in your decision, and oral agents are preferred over IM. First line should be behavioral interventions, as it limits adverse effects, but there is the need for education and training of staff and caregivers. Second line would be pharmacologic agents, which I would start with SSRIs, as they've been shown to be effective and are usually well tolerated. Would then try atypical antipsychotics or gabapentin, which picking one of those would depend on other possible behaviors. If they have more aggression or any type of hallucinations, an atypical antipsychotic may be considered. Finally, I would try hormonal agents, as they have a lot of side effects, and as well there are other ethical dilemmas to consider when initiating these types of therapies. I introduced Mr. JW in the beginning of the presentation. I just want to go back to him and show what different therapies he actually received. He received multiple different types of antidepressants, as well as anticonvulsant, donepezil, memantine, and galantamine. These were all given in different combinations, and he did have periods of complete resolution of ISB. Initially, the wife and daughter did not want to start NPA, but they were then agreeable, and was eventually started on 10 milligrams daily, which is much lower than what I reported in the case reports. It was titrated up to 30 milligrams daily, and his testosterone levels were checked periodically with almost a 50% decrease. The challenge with this patient was that he continued to have increased apathy, which limited target doses of some of the therapies, as well as he received care from multiple outside providers, so the continuation of care wasn't always clear. He also did not receive any neuroleptic therapy because he was diagnosed with dementia with Lewy bodies, and usually those patients are very sensitive to those types of agents. I think he's a good case to show how complicated managing and treating these types of patients are, as well as how much these behaviors can interfere with the patient's lives, as well as their family and caregivers. I did state earlier that there are more case reports. I only presented a couple of them, but if you're interested in receiving a table that lists all the case reports that I've compiled from the literature, you can email me and I can send those out to you. And now I'll take any questions.
It's interesting, the topic of your presentation, because I've received I'm a psychologist, and my area of specialty is one of my areas of specialty is gender identity. And I've worked with a lot of transgender veterans, and I received a consult and I saw a patient who was not a very good historian, but male to female, genetic male who identified as female for some amount of time, who was referred to me because she, and I'm referring to her because that's how she identifies herself, was being sexually aggressive, was touching female patients. And when I talked to her, she had a lot of dementia, and she wanted sexual reassignment surgery. Of course, she does not have the capacity to consent to that at all. But what you said about the hormonal agents, I'm wondering if that's a win-win situation, because she would have no problem with chemical castration. So what are your thoughts about that?
There, I think if I remember correctly, was some data with those types of patients. I kind of was just more specific to dementia patients, but I agree with your statement that seemed that would be appropriate. I mean, I definitely think the hormonal agents are effective. From all the case reports I reviewed, they just have a lot of risk associated with, and depending on the types of behaviors and how severe they are, would be when I would choose to use those therapies.
Yeah. So if the risk could be managed well, then that might be a win-win situation. Thank you.
What kind of behavioral studies, when you say behavioral studies, what kind of behavioral studies did they do?
For some of the case reports, I think I had mentioned the two case reports where they said they tried behavioral interventions. Is that what you're asking about?
Right.
So that's kind of the problem. They don't really say. If you look at a case report, they're very vague, usually in the type of information they present. So in those two specifically, they didn't say what they tried. They just said that they used behavioral interventions. And I would say overall, when looking up behavioral interventions specifically for inappropriate sexual behavior, is overall very vague. So it's hard to give guidance of what to try. The ones I presented were the ones that I saw most throughout the literature that was recommended. But again, it's very vague.
They want to look to the diversion and distraction, involving in different types of activities.
Yeah, those are the most commonly kind of typed in. Usually, I guess, when looking into the behavioral interventions, sometimes they lump all types of behaviors together if they're really aggressive, which may not be exact. It's not the same as sexual inappropriate behavior. But a lot of the studies, if you look at, they'll have all kind of behaviors listed together, and they don't define what they did for each different types.
And in some of the literature, did they talk to any of the legal ramifications, the rights of staff or other residents?
They didn't go into a lot with the staff or the other residents. Some more for the patient with the chemical castration. Some of the case reports, they didn't give a lot of detail, but there, I remember correctly, at least two where state regulators came in and saw that the patient was on a hormonal agent for that purpose, and they made them discontinue therapy. And when I look to review, what is actually stated, it's very vague. So it might depend on each area you're in or who comes to review that. But I didn't see a lot pertaining to the staff or other residents.